talking about is really named after Sebastian Ferraro, which many of you realize was a little boy who died because of medical error. And being kind of organization that we are, we partner with the family to really make sure that that never happened again. I have a team of folks who work in a number of different areas: quality, patient safety, patient experience, and really our job is to partner with all of you that are close to the bedside to really make those kinds of changes that we all want. And this is really exciting. And I know you have done some amazing and exciting work. Are you going to talk a little bit about the work you've done in the operating rooms?
Well, actually, I was afraid this would be rewarming and old lecture, so I put that at the end. I thought we won't get to it.
Oh.
And actually, it turns out to be wonderful because this branch here is all PhD in pharmacy, graduate students. So I'm going to actually talk instead of race-specific pharmacodynamics. And just for their benefit, they might not know about Ferrero. I think it would be helpful if you wanted about the aspect of it.
This was a little boy who was basically an elective procedure in our clinics to administer a growth hormone. And there was a lot of miscommunication in terms of the dosing and the medication that was delivered to the clinics, and despite some real concerns from the family that were voiced to the team, nobody listened. And at the end of the day, this little boy got a significant amount of medication that his body could not tolerate, and actually died. And some of the things you, the story, there's a website with stories there, but you really changed the face of this organization. I was not here. I know, for example, Dr. Gravenstein was. It truly changed the face of UF and UF Health. In addition, it changed the curriculum. I don't know how many, there's interprofessional work that goes on. There's a lot more safety and quality work that's going on. So it was really an awakening. Many of you may not realize the pediatric emergency room was a direct output of that. He was brought to an emergency room that was actually an AGH at that time. It wasn't set up for kids. So that was an output of that. All of the changes that have been in the pediatric hospital are directly related to that, to really pay much more attention to children.
Yeah, I just wanted to make a note or a comment when you said that the family had concerns and tried to express that. I think it's important to note that the family, because I've had a chance to meet with them, they're very intelligent, very professional, very affluent, but English is their second language.
Right.
And I think that's a really key factor in the fact that sometimes if you're, how you listen or how that was communicated.
Absolutely, and I think, as I was not here, but as I watched the tapes and heard the messaging, that is truly, of all their things, recommendations, listen. What Luce is always saying is listen to the family. They know their loved ones best. But I do want to put a plug. That is one of the most unrecognized patient safety challenges we have, patients who do not speak the language. Those of you who are delivering care, we have a full interpreter service. So if any of you ever run into that, there's help for you, for your patients. But that is really true. They just assume the assumption of the patient. So thank you for raising that. That was definitely contributing to that. Any other? Thank you.
So thank you so much, Randy. And so there's definitely a tie-in between simulation and safety. And so we're going to try, and Randy is going to suggest some speakers for safety topics. And if you can suggest some topics too, we would welcome that. So without further ado, I think we will start the lecture. I would like to acknowledge the anesthesia department and the CPSI for essentially making this happen, and Randy. Faith Hawks is over there. She's the one who organized everything, and I already discussed whether there is a perceived need for a simulation studio, and what I heard was yes, so we will start that process, and please provide us suggestions for further topics and filling your form. So today, I'm going to talk about some translational simulation healthcare initiatives. I have the standard UF disclosures. And this is the lecture outline. So we're going to talk today about first of all, what is simulation, on the assumption that some of you may not be familiar. Then what is translational science? And then what is the combination of the two, which is translational simulation in healthcare. And then we'll follow up with 3 initiatives. There's more than that. There's 3 initiatives to exemplify the 3 main skills, which is psychomotor, cognitive, and affective. So if there's one slide you want to remember, it is this one. Simulation is not about mimicking reality. A lot of people who are novices to simulation, they say, the mannequin doesn't look like a real person. The skin doesn't feel like the skin. Well, if what we are simulating is not relevant to the skin, it doesn't matter that the skin doesn't feel like the real skin. Instead, simulation is about providing a medium to train people to acquire skills. And this is a graphic to show that same thing. It's called a simulation triangle. So essentially, you have affective skills. And here's an example of affective skills. And the reason I had that first, as Randy just discussed, when we do root cause analysis of how patients get hurt, surprisingly, communication and teamwork is very high up that list, and that's called affective, because nobody takes care of a patient alone nowadays. You have a team taking care of a patient, and if you don't know how to interact, you don't know how to be a leader and delegate, you don't know, if you're a nurse, you don't know how to speak up to the surgeon to protect the patient. All these things can lead to bad outcomes, and that's affective skills. Cognitive skills is really, in plain English, about thinking and knowing, and I'm going to cover that today, which is the patient-centered knowledge and practice, specifically of Propofol, race-specific Propofol pharmacodynamics, and then psychomotor skills, which is knowing how to do something, having the skills, having been able to practice it in a safe simulation setting before you do it on a real patient. Just a quick primer on terminology. Very often when you read medical journals, you will see those 2 terms, and they're sometimes used synonymously, which is actually inappropriate, because if you look at the highlighted text, something is efficacious if it works under ideal conditions. So I have a well-trained person, I have a very compliant patient. When I say take your drug every 8 hours, he takes it in the right dose every 8 hours. When something is effective, it works in an average environment, which means that patient, sometimes she remembers to take it, sometimes she doesn't. The clinician who does the treatment may not be optimally trained, but the system, the process, the system, the device still works, it's effective. In evaluating interventions, whether it's simulation or educational or even a process, a medical intervention, we look at those, what's called the Kirkpatrick levels. At the very first level, it's reaction. So in the case of simulation, we want to have what is called suspension of disbelief. When somebody is in the simulation, they must think they are in the real situation. And surprisingly, the realism of the mannequin and all that is not crucial to that. A lot of people intuitively think, oh, the mannequin looks like a mannequin in the department store, so therefore I won't believe in it. But once you put all the other elements in place, people will suspend disbelief. The second level is beyond accepting the simulation and suspending disbelief, you want that person to also learn. So if they invested 10 minutes or 1 hour into your simulation, after they have done this, do they know more, whether it's affective, cognitive, or psychomotor skills? After that, what you're concerned with is when they leave your lab, do they go back to the OR or wherever they work in the UF health system, and do they internalize this? Do they actually take it to their patients? Because I may teach a nurse who has done a skin prep the wrong way for 30 years, Then I show her the new way, but she's done it for 30 years. In the lab, she sees me watching her. She's going to be on her best behavior. She leaves the lab, she goes back to the OR. She's done it for 30 years. It's like breathing to her. Is she going to change the way she did it? Is my 10 minutes or 15 minutes of interaction with her so impactful, or with a simulation so impactful, that she's going to drop 30 years of bad practice? And then finally, we are not even looking at behavior in translational simulation in healthcare. We're looking at results, right? Our patients having less infection, if we took one group of clinicians that trained with a simulator and another that didn't, everything else being the same, are our patients getting less infections. And because we live in a world where money is always an issue, so now there's also a fifth level, and Kirkpatrick argues that they should really be the same, but it's considered a fifth level. It's the return on investment. Because if I build a simulation for UF Health, and it takes $20 million to run a year, and then Ed Jimenez comes to me and says, that simulation saved me $10 million of complications last year. The ROI doesn't quite fit, because I'm spending 2 times as much to save $1 of complication. It sounds cold-hearted, but this is the reality of simulation right now. So not only do we have to make it efficacious, we also have to make it a good return on investment. Any questions so far? Okay, so what is clinical and translational science? The 4 slides you're going to see are borrowed from Dr. Nelson, who is the head of CTSI. So you start at, it's called T1. At T1, Translation 1, Phase 1, you have a basic science discovery, and you're looking at a potential application. So you're going from basic to theoretical. It's called bench to bedside, animal models. For drugs, you have Phase 1, 2 trials. And then when at Transition 2, you're looking at evidence-based guidelines. So now you've done your Phase 3 trials, and you've done your observational studies, and you decide, do we have enough evidence base? And you have efficacy knowledge at that point. And then at T3, you go to Phase 4. So at Phase 4, interestingly, the drug is FDA approved. So I don't know whether you guys have studied that for the PhD in pharmacy. To me, this was a revelation. When a drug is approved by the FDA, all we know is that it's efficacious. We don't know that it's effective. We only know if it's effective in the Phase 4 trials, because then it's being prescribed to the entire population, and then we do those follow-up studies, and that's when we find out how it works. Okay, so this is the 4 steps in translational science, and now this is the same thing adapted, but for simulation in healthcare. So we have an unmet training need. We identify there's too many infections. People are not doing the skin prepping the right way. So we create a simulation based on pedagogic design. Then we have the new simulation. We decide that with the current engineering technology, we know how to build that simulator. And then we transfer it. And here we have a 2-step process. So we transfer it first to clinicians. It doesn't go directly to the patient. So in simulation in healthcare, it's always the transfer is indirectly to the patient through the clinician. And we look at our Kirkpatrick levels and whether it does what it's supposed to do. And usually that's the end point of simulation in healthcare currently. So with translational, we go from clinicians to patients. And that's the Kirkpatrick 4 and 5. Do patient outcomes get better? Is the ROI positive? And we have efficacy knowledge at this point. And then we transfer it to the community. And there we begin to look at interracial PK/PD variability. And that's patient-centered medicine, essentially. And if we get to a point where the simulation works, even if people are not optimally trained, and they don't work in a hospital with optimal conditions, the simulation still makes a difference, then we have effectiveness knowledge. So that's a pretty busy slide, but I thought it was good for you to be able to see the two next to each other. Okay, so you have a few more steps in translational simulation in healthcare. So I'm going to now jump to the first case as an example of translational simulation in healthcare. So you're going to see a technique for regional anesthesia where the current techniques that are used have known drawbacks because we're going to use, so let me show the video and then I'll continue from there because it's probably easier if you see the video first.
Welcome to the Regional Anesthesia Mixed Simulator. This compact unit simulates the proper procedure for thoracic paravertebral blocks and placement of thoracic epidurals with and without ultrasound guidance. It is dry, requires no fluids, and may be set up in 5 minutes. The simulation contains a physical spine encased in gel, a virtual model, a tactile feedback system, a tracking system, and a scoring and replay system. The virtual and physical models are based on scans of a real human. The virtual 3D model depicts soft tissues and anatomy. The nerves, spinal cord, ligaments, arteries, veins, and lungs exist only in the virtual visualization. The virtual model is co-located to the physical model, which has skin and bones. Replaceable skin patches cover the underlying gel and spine. The visualization mode button can toggle the visibility of the anatomical structures. One mode is ultrasound only. Other modes provide 3D color images of bone, ligaments, blood vessels, and nerves. The level of difficulty can be varied by increasing or decreasing the diameter of the subdural space. The viewpoint of the virtual model can be controlled with a virtual camera pointer. Hold the button on the virtual camera and move around the physical model. The virtual viewpoint will follow the camera and move around the virtual model. Release the button to freeze the virtual camera's position. The simulated ultrasound images are generated in real time according to the position, orientation, and applied pressure of the physical probe that is tracked in space. Markers show depth in centimeter increments. Cognitive aids can be used to draw a midline over both the virtual ultrasound image and the incidentating plane within the visualization. A sheet of red light depicts the ultrasound incidentating plane in the visualization. In one of the visualization modes, a hybrid cross-section displays all anatomy behind the cross-sectional plane. The simulation model.
All right, so I think you got an idea through this of what the simulator is. So I'm going to show you what the issue was. So this is the standard disclaimer that this is funded partly by DoD, but essentially, in plain English, we're going to try and get a needle into this space. This is called the thoracic paravertebral space. The reason we try to do that is this space and this space and this space, so everywhere below the ribs, those 10 spaces are in communication, or in fluid communication. So you have a soldier, this is funded by DoD, who's been in an IED blast and he has 4 broken ribs. One way to treat those 4 broken ribs so that the soldier can be evacuated to Germany from Afghanistan is to put 1 injection here, so 4 separate injections, 1 for each rib. The thoracic paravertebral, if I get my needle in here and I can deliver my dose, I do 1 injection and the fluid will spread and numb those 4 contiguous ribs. And why do I want to do only 1 injection? Because each time I do an injection, I risk going into the lungs. So if I do 1 injection versus 4, I've reduced my probability of going into the lungs by a factor of 4. Because if I drop the lungs, now the soldier, instead of helping him, I'm putting an additional complication on him. So this sounds straightforward, but in real life, when you look at your ultrasound, this is what you get. And here you have 1 rib, and here you have another rib. Your needle is actually here, but you can't see it. And the reason you can't see it is, and I'll get to that later, but you can't see it for now. Now, in the previous slide, let me go back. We had the probe normal, and And here now you can see the probe is slightly slanted. Oh, I think I jumped. Oh, sorry. I'm not used to this remote control. Okay, let's try this again. So here we have the probe normal, and when we do that, we can't see the lungs. So if you look here, the lungs should. So for those who are not used to ultrasound, this hump here, that's this rib. This hump here, that's this rib. Actually, I have it backwards. This hump is this rib, and this hump is this rib. So, and then this, do you see that faint line here? That's the ligament. Okay? But the lungs are not visible. And that's because the way the sound energy is hitting the lungs, because the lungs curve inwards as it reaches the spine, that angle of incidence is such that the sound energy, instead of bouncing back to the probe and creating an image, this is the probe face here, it bounces away. So the lungs are invisible. It doesn't mean they are not there, they're still there. And that's the part of the learning objectives of the simulator, is to prevent you people who do this technique from inadvertently dropping the lungs. And that's the image you see. So this is one rib, this is another rib. So to get a better view of the lungs, we tilt the probe to one side to make a better angle of incidence. And you can see now the insonation plane. That red sheet of line is the insonation plane. It's hitting the lungs here. And now do you see it? You see the lungs and the ligament. But when you do that, it's much harder to keep your needle parallel to the probe because the probe is not perpendicular. It's tilted. And so that's the view. And you can't see the lungs. And you could see the lungs this time, I'm sorry. So let's go back. You can see the lungs, and here's the lungs, right? So you can see the lungs. And now we bring the needle in. And as you bring the needle, you can see the needle is not in the picture. But if we, on the simulator, we can play with the physics, and now we can actually see the needle. And you can see that this needle, if I keep pushing, it will go in the lungs. And so that's not a good approach. But why do I need to take this steep angle? Because I have to negotiate this bony hump here, which is called the transverse process. So I have a very narrow gap. I have those bones in my way, and I have to bring my needle at a sharp angle. But when I bring my needle at a sharp angle, all the ultrasound energy, instead of bouncing back to the probe, bounces away. And now I don't see my needle. So that's the danger with this established technique. So with our approach that was developed by Dr. Inatsenka, a resident here, instead of coming in at, if you remember previously, the probe was at what we call the 12 o'clock position. Now we come in at the 11 o'clock position. But you also see how this part of the rib is higher, the transverse process, than the rib. So by coming in at the 11 o'clock position, you come in at a lower obstacle, you can come in shallower. And when you can come in shallower, your needle is visible on ultrasound. And your path is also directed not to the lung. So that's the technique again, you can see that. The needle is going to go here. And here is an actual picture, so that's the translational part of it. So this whole new technique was developed, inspired by a simulator, developed with a simulator, refined, and then we took it to a patient. So here's with a real patient. Here's the rib. You can see the rib is lower than the transverse process, so therefore the needle can come in more shallow. And that's the needle, that's the ligament, and that's the pleura. And now you should be able to see. And here's the video for you. It's a quick video. And the interesting part, if you look here, you see the lung going down, because when the needle is there, we actually inject anesthetic, and the anesthetic pushes the lung down. So the simulation can do all these things. So that's the first application. And remember, we had this translational simulation in healthcare roadmap. So I would submit that in this whole process, we are right here now. We've developed a technique, we've developed a simulator, we've developed a technique, and this, by the way, we believe is a first in simulation in healthcare, that a simulator inspired a new technique. So we've sent it for publication, and right now we've already taken it to patients. We're going to do another study. We're submitting the IRB forms right now to test the efficacy knowledge, and then later on we will probably test the effective knowledge too of the simulator. Any questions about this case before we move on to the next case? I know it was a very specialized field, but within the domain of simulation, it was very interesting because it dealt with psychomotor skills, and it also dealt with the fact that a lot of what we try to do as scientists, it's really what we call a black box. We don't see the Krebs cycle. We don't see the pharmacokinetics and dynamics, right? These are all, in the end, very abstract terms. And in the case of even the human body, even with those ultrasound probes, you saw what kind of image they produce. So to me, it's like reading tea leaves. So I'm always surprised and impressed when my clinical colleagues can look at those ultrasound images and make sense out of it. So we are trying to peek into those black boxes, but it's hard. And simulation can jump beyond reality and allow us to see things which we cannot see, and in doing so, allow us to invent new techniques. Because the person who invented it, he's been using that technique for 10 years at least. So he had ample opportunity using a real system, meaning a patient, to develop that technique. But his ability to visualize was limited, and the simulator allowed him to visualize better. So this one, I didn't know there would be such a big show from the College of Pharmacy, but this is what I picked as the second case. So this is patient-centered simulation for patient-centered propofol sedation. And we modeled race-specific pharmacodynamics for this. It was funded by R21 from NIH, and we consulted with Dr. Derendorf quite a bit on this too. So this was the group, and so some of the key concepts that are needed to introduce the application is there is data coming now from emerging countries like China and India that Chinese and Indians from the South Asian subcontinent are more sensitive to propofol than Caucasians. And there are multiple studies that have been done. They all find the same thing. When you give propofol, one technique is to give what's called a loading dose and then use top-ups. And the loading dose typically is based on a milligrams per kilogram. If you have so many kilograms, I multiply my dose, milligrams per kilogram, and I give you that loading dose. And usually, they just give the whole shot in a bolus. Then there's also the concept of titration to effect, where I give a little bit, I watch how you're doing, I give a little more, I watch what you're doing. Why is this not used more often, the titrate? Because that makes sense, right? I give you a little bit, I watch how you're doing. Because most of us are not cookie cutters from cookie cutter machine. We react differently to propofol. And I'll tell my personal story later at night. So why don't we give a little bit, see what happens, give a little bit, what happens? It's time, right? Time is money. So in the way medicine is practiced, we'd rather give the full dose rather than titrate to effect. So we're going to, I'll skip over the rest of these for the sake of time. And then we have pharmacokinetics and pharmacodynamics. For those of you, I'm sure you understand that. For the non-pharmacy people here, one easy way to understand pharmacokinetics is to think of it as what the body does to the drug. So if you take a drug, whether it's aspirin or propofol, as the drug gets into your body starts breaking it down right away. So that is what we call what the drug does, what the body does to the drug. But then once the drug gets to the site in the body where it does its effect, the effect site, then this is what the drug does to the body. So in the case of propofol, it may reduce your breathing. And so we created first of all, a compartmental model of propofol, and that model is available free of charge here. So I would encourage you, if you're not familiar with that website, to go take a look, because it's also graphical in the sense of we show a hydraulic analog. Dr. Hockhouse has excellent simulations of drugs on his website. He has those excellent plots. Our approach is slightly different. We show a hydraulic equivalent of the compartments, and then you can see levels move around. So during propofol sedation, ideally you don't want the patient to totally lose consciousness, because then you are in what we call general anesthesia, and the patient loses what we call their self-protective reflexes like breathing. And so why is this important? There's multiple cases of propofol sedation gone wrong. There was a case in Florida during breast augmentation. Here is somebody even wrote a book. This is a gentleman whose daughter died during propofol sedation for breast augmentation. And he went and investigated and saw all these instances where things went wrong. So that was her daughter. She was, I believe, 36 years old when she died from propofol during breast augmentation surgery. And of course, you all know Joan Rivers. That's the most recent case. So she was having propofol sedation, and I believe she stopped ventilating. And on purpose, I left Michael Jackson out, because that was not a sedation case, obviously. It's not meant to be a sleeping aid, right? So for the effect side, we use the choice model and his correction to the Marsh propofol model, because when we did the first simulation, Nick Gravenstein was our clinical expert, and when we kept running it, he kept saying, our propofol was coming in too slow. The peak effect was coming in too slow based on him giving it daily in the clinics. And so then we went and investigated further in the literature, because currently the Marsh propofol is the one on which even the infusion pump devices in Europe are based on. And luckily we found the Struss paper where it said, yes, this model is wrong. You should have this correction. So when we added that, Nick was happy and we were happy. And this is what I meant by the hydraulic analog. So this is how we model propofol. You have a central compartment for plasma, and then you have a fat compartment, and then this is the effect site concentration, and we had the Struss correction to the Marsh model in there. And this is the part where I was talking earlier with Hartmut, Dr. Derenbo. So this is the simulation part. So in clinical practice, the way we assess how a patient is doing is we look at how they respond. So somebody is declared conscious, and these are the levels. We actually say OAS 5, OAS 4. You look at, they declared conscious if they are at 3 and higher. So if I call your name and you respond, you're at 5. If I call your name, you have a lethargic response, you're at 4. If I have to speak your name loudly or repeatedly, then you're at 3. If I have to shake you for you to respond, you're at 2. If you don't respond, then you're at 1. And then if you don't even respond, if I'm cutting you and splitting you open, then basically you're at 0. You're at general anesthesia. And so in the simulation, we had to simulate that, because we were going to study how the care providers at UF were actually administering propofol when it was underdose or overdose. So this is what we did. We had those patient symptoms, and let me see whether this video will play. So this is the patient, and you can see clearly this patient is, would be the symptoms of not being sedated, right? And depending on what was the effect site concentration relative to the target effect sites, we were then playing all these different video clips to simulate the different levels of sedation. Yes, you don't want your patient to be doing that. So, and then additionally, and this is something that I welcome the comments of Dr. Hockhouse and Derendorf and also the pharmacy students. So we give sedation because it's a painful procedure. In this case, it was an upper GI endoscopy. So that's painful. So we had to find a way to simulate pain. So we simulated pain as the antidote of sedation. That was Nick's suggestion. So, and that's what we did. And so if there was a pain event here, we would essentially shift a lot of the effect site concentration thresholds and make the patient more awake, even though the dose of propofol would say that patient should be asleep now, because the pain acts as an antidote to the sedation. And then that effect would last for a certain amount of time and then decay. In this case, I think it was like two minutes or something like that. And then EC50, it's a fancy word, but it just means like 50% of the population will respond, and the other 50% will not. But what we did is we altered it based on race. We didn't just use the data that's in the package insert, because those were based mainly, one of them was actually based on data set from Germany. So there was a gentleman named Fechner. He designed the first Propofol pharmacokinetics and dynamics. First Propofol is a prodrug for Propofol. So we used his model, and then I was suspicious most of his patients were Caucasians, so I emailed him. I said, can you confirm all your patients were Caucasians? And he actually did email me back, and he confirmed they were all Caucasians. And so here's the race-specific Propofol data. So Irwin did a study in 2002 with Hong Kong Chinese patients, and this is what he found. He found that the loss of consciousness was 2.66, and his data was also confirmed by Lee, and he got a little bit different, but much lower effect site concentration for Chinese compared to Caucasians. And this one was done for blacks. So this was blacks from Great Britain and Caucasians from Great Britain. And again, if you do an adapted effect site concentration for loss of consciousness, it's at 2.02. And then Puri did a study in India, and he got an even lower concentration. Yes?
If you assume that the pharmacokinetics are the same across?
Yes. That's there have been some people who've looked at some blood assays, and from that, they seem to think the pharmacokinetics are identical. It's just the way the pharmacodynamics are what's different. Yes. Good question. So actually, you preempted my slide. So yes. So then the profile, the concentration profile is the same for all the races, in our simulation at least, and then the difference is due to the pharmacodynamics. So this is the table we created, and then there were some differences, like this guy reported the central compartment, so we adapted it to the effect site. So when you have that, then you have Caucasian stand at 2.8, Chinese at 2.6, 2.2, depending on who you want to believe, black at 2.02, Indian at 1.88. And that's in the literature, and then later on I'll show you actually a package insert. And then what we did, as I said, this is again the simulation part, where we have the pharmacokinetic modeling, but then we put the patient's symptoms on top. And then we also factor it for race, right? So the thresholds are different for each race. And we did do a linear interpolation. I don't know whether that's justified, but we had to start somewhere. So we already talked about the loading dose, and this was the setup. So we had a mannequin, and we had a video of a virtual patient so that we could readily turn the features from Caucasian to black to Indian. And here they are, Caucasian, black, Indian. And that's the beauty of mixed simulation, because you don't have to buy different mannequins, which is expensive. The participants filled a questionnaire, and then we looked at what they said they would give in the questionnaire versus what they gave in the actual simulation.
Confusion's going to go down to 200.
So this is a white male patient, and now there's a, I believe, Indian patient. Yep, South Asian.
Confusion down to 200.
And the vital signs are being displayed here. This is a video of the upper GI endoscopy. So that was our setup for conducting the study, to see how they were dosing, whether they were taking the race of the patient.
Remain okay.
And this guy didn't, this patient, I think he had quite a few instances where he lost consciousness. And the person doing this, by the way, he does a lot of sedation. He's our go-to guy for sedation. So that's why I picked him. In all, we had 23 males, 14 female faculty, residents, nurse, anesthetists. The age ranged from there, and the experience delivering Propofol ranged from 6.8 to 2.58. This is the data from our pharmacokinetic, pharmacodynamic model. So this is how the drug was being given. These were the jaw thrusts that were being given because the patient was giving signs of being overly sedated. When the scope went in, so that's a big spike in pain. So therefore, all the thresholds got readjusted. When the scope came out, similarly. So, and this one is for the South Asian, and this one is for the African male. Bottom line, this is what we got. So the loading dose, and the patients all had the same weight. They all were 70 kilograms, they all were male, they all were in the same age range. So if you look, this is the range, and then this is the mean. So the mean is very similar, and the ranges are very similar for the loading dose, irrespective of race. Now, the total administered amount of Propofol was actually different. So the Caucasian got 1.95 milligrams per kilogram versus 1.63 for the Indian. The loss of consciousness duration, which is undesirable, so the shorter the better. The Indian was unconscious, meaning he was below a level of 3 for 207 seconds compared to the Caucasian for 147. And then in addition, once we pull the scope out, the pain stimulus is gone, but then we want the patient to be at a OAS of 1, fully recovered. So the recovery time, again, was significantly different, 522 versus 444. And so again, this was data collected with actual people who use Propofol. And I already sort of touched on this. We had significant differences in loss of consciousness duration, total consumption, time to fully conscious, but no significant difference in loading dose, which then leads us to assume that it's really being very formulaic medicine or cookie cutter medicine. Caucasians spend significantly less time over sedated, so we already touched on that. Propofol consumption significantly higher in Caucasians compared to Indians and blacks. The time to recovery was much shorter for Caucasians compared to blacks. And I already talked about that. Okay. So our preliminary conclusions is that when clinicians do a loading dose, they should really consider the race of the patient instead of giving the same dose they would give for a Caucasian. We took that same questionnaire to a big international meeting, and essentially our data showed the same, that the mean that would be given was very similar for the loading dose, so there was really no difference between those three patients in the way, because we were wondering whether what we saw was simply because we are in Gainesville, it's a little town, not cosmopolitan, people are used to handling white patients. So we went to this big meeting, I think it was in San Francisco, and it's 23,000 people from all over the world. And this is what we saw. It was pretty much the same. People were using formulaic dosing. Okay. And then there's also anecdotal evidence. I was at a meeting in Shanghai, and I met an anesthesiologist from Taiwan there, and he said, yeah, we just dose everything lower. And more recently, one of our colleagues, Jeff White, he joined us from San Francisco. He practiced with a lot of Asian population patients there, and he was very categoric. Yes, Chinese people are more sensitive to propofol, and that's based on his experience anesthetizing a lot of them. And interestingly, this is a package insert for North America. I don't know whether you can read it. The dosing instruction is 40 every 10 seconds. If you look at the package insert for India, 20 milligrams every 20 seconds. And you could argue now we live in a globalized world where, if you practice in New York, your patients could subsequently be Caucasian, Indian, and Chinese in one day. So I'll skip over that. And yeah.
What's the standard deviation within for the EC50 values?
I can go back to it, or I can email it to you. It's fairly wide, because within those groups, just like within Caucasians, there is variability, right? So, for example, we know that redheads need more anesthetic, and they are Caucasian. So I believe it was pretty wide. And so where are we on the clinical and translational science part? We are really here. So we have a simulation. We have done it. We have validated it based on people using it. We could build another simulation, but before we go there, we really want to make sure that it is accepted and answer questions like you've asked. And then we will take it to clinicians and to our society and maybe come with a different recommendation that, you should really, as part of your dosing, take race into account. Yes?
Has anybody looked at EEG response between the...
Oh, that's a great suggestion. No. So that OAS, as you can tell, is all subjective, right? Yeah, so EEG would be a wonderful thing to use.
It's just tough to do in live people because there's so much EMG when you don't have a general anesthetic going. There's too much muscle artifact.
But to see if there is a tendency that in Asians there would be different use of 50 using...
Certainly in unstimulated people, using a standard induction dose, you could see how low the EEG would go and give a muscle relax at the same time.
That would be a study we could do. And, I think I skipped so let me share with you my own, we also call simulation experiential learning, because you learn by experiencing. So I had my own experiential learning with Propofol. 3 years ago, I had a colonoscopy, and they told my wife I would be out in like 45 minutes. I was not out after 1 hour and 45 minutes, and she got concerned that something went wrong. And what it turned out to be was I was given the whole stick for a Caucasian. Do I look like a Caucasian? Right? So this tRNA was not aware, obviously, and I was not aware at the time, by the way. So they had to take me to the PACU because I was blocking the procedure room and woke me up there much later. So this year, I had another one, right? And because it was here at UF, I talked to the anesthesiologist and I said, hey, make sure you titrate me. Don't give me the stick. I gave them the whole story I gave you. I said, just go slow, take your time. And he did. So, and then I woke up, everything went according to plan. I said, how much did I need? A third. A third, and I was gone. So it just tells you, clearly this is an N of 1. But I remember actually it's an N of 2, because 3 years ago, when they gave me the whole stick, I didn't do that well. Luckily, I didn't need to be intubated. And then 3 years later, they titrated me and they say, oh, you're good at it, you're a cheap date. So this is where we are. I don't think we'll have time to go into the other one, so I apologize for that. I wanted to show you an example of affective skills. But I think it worked out well because there's a big audience of pharmacy people here. But you can see how this would work out from a translational point of view, because we use simulation to, like you said, can we use EEG? So in a way, those simulated patients, we had the models running. And as they were doing jaw thrusts and all that, the patient was reacting accordingly based on those symptoms we had programmed. And based on that, we actually saw what essentially the model predicted, that the Indian would get overdosed, he would take a longer time to wake up. And granted, within each group, you will have variability, because my wife also had the same procedure, and in her case, she took the whole dose. She needed the whole dose, and she's also Asian. So there is variability within the group, but I believe those averages still mean something. Any other questions I can answer?
So maybe one comment. It's not just racial differences, also age differences.
Yes.
We have more and more very old patients, and for example, benzodiazepines is a good example, where you have the same thing, that with age, sensitivity goes up. And
yeah, age and sometimes gender even. Also. So that's an area where we're doing work. I think it would be interesting to do the same study with opioids, because that's also used commonly in anesthesia. And there is already anecdotal evidence that there are racial differences in response to opioids. So if any other PhD candidates here are looking for projects, since we have time, yeah, go ahead.
Just want to congratulate you, because I think it's really a wonderful thing that you use those simulations, but that you actually build in input from the medical doctor making decisions.
Right.
That's really, I really like that very much. On the other hand, simulations are also being used, for example, to optimize clinical trials.
Correct.
And it might be, and that's what Hartman and I are doing right now quite a bit. And it might be something that maybe the CDSI also might see some benefit in, that one really can optimize the planning of studies by just incorporating variability and all that.
Right. Yeah, that's a great idea. Robert Cole is here. He's from CPSI, so he's taking good notes. Yeah, actually, let me see whether I can take you to the, I think I had a simulation of the Propofol, and I can show you the intervariability. I guess I thought I had it. Let me see what I can just pull it from the. Yeah, it's certainly been very helpful that we had the support from CTSI for this. And I'm going to show you the Propofol simulation we have on the web. Computer is taking its time for some reason. Well, I guess the computer is in sleep mode.
Too much Propofol.
Yeah, too much. Exactly. Well, I think it was a great turnout. We would welcome your comments if you have any comments. The other one I was going to show, let me just show it to you briefly, actually, because since we have, actually, except it seems my computer is frozen. Oh, there it is. So it's a Propofol simulation with 3 compartments. It's on the web. And this is the loss of consciousness threshold. This is the recovery of consciousness. So this is an initial bolus, and then you give a second bolus at this point, and that's why you get a pump, right? And then Nick Gramenstein is here. He suggested we put this interpatient variability. So what I'm going to do is I'm going to click on this, and as I click on this, watch how the plot changes. And this is how we did it, is we looked at the parameters here. There was the volume of distribution and all that. There are usually standard deviations around them. So we randomized those parameters so that they would oscillate within that standard deviation. And so you get those and that's what you would see, irrespective of interracial differences. Within a race, you would see things like this.
And it's probably going to be even more pronounced if you would model the pharmacodynamics of it.
Right. Yeah. So that's the realm we're dealing with. And then the last presentation that I won't cover because we only have 5 minutes was to show affective skills, and that's speaking up. There is a way for a nurse, for example, who is lower on the hierarchy, to a surgeon, to talk to the nurse, to the surgeon, if something bad is happening, and protect the patient. And it's a very professional way. It's been defined and formulated by the Agency for Healthcare Research and Quality. And so that's what we also did. And maybe we'll save that for another lecture. So thank you all very much. We're ending a bit early. It's great attendance, great questions. Thank you for coming. And,